Hey guys, it's Matt Kinney, back with the second of 3 radiology lectures. This time, we will focus on CT, an advanced imaging modality that is incredibly useful for evaluating the brain and the abdomen, and has specific indications for diagnosis of disease in the thoracic cavity as well. As we did in the first radiology lecture, we will start each section by discussing the indications for ordering CT exams, since those are the most common questions you will be asked about on your exam. And then we'll go over an example of a normal CT before getting into the classic pathological findings associated with specific diseases. But first, let's spend a second actually talking about what computed tomography means. At its most basic level, computed tomography is just advanced manipulation of an X-ray, or, put more correctly, lots of X-rays. Using X-ray radiation to produce an image just like with a plain film, a CT scanner is capable of collecting hundreds of X-ray images from many different angles within a matter of seconds. A computer then takes this array of two-dimensional images and reconstructs them to produce a three-dimensional model. This allows for visualization of images in multiple planes, especially in an axial plane, which is how CTs are most often presented. Along with the ability to quote-unquote see inside structures due to the 3D capabilities, CTs also provide increased detail clarity, which can help differentiate structures that may look very similar on a plain X-ray. And finally, due to the digital images produced by CTs, there is the capability for windowing, or using the computer to enhance a specific tissue type, such as bone or brain tissue, to better evaluate for specific pathology. While CT is an amazing technology that has revolutionized medicine, it is not without drawbacks, and these drawbacks are often tested on the Step 2 CK exam. First of all, as we just discussed, a CT is like getting several hundred X-rays, which means several hundred times the radiation of a single X-ray. Thus, CT should be ordered sparingly, especially in small children who are more sensitive to the effects of ionizing radiation, and should never be ordered in pregnant women. Also, many specific types of CT studies require intravenous contrast to help differentiate blood vessels from other anatomic structures. Unfortunately, many people are allergic to this contrast and, in the worst case scenario, it can cause an anaphylactic reaction. Thus, if the question stem mentions an allergy to IV contrast, take it very seriously and don't order a CT with contrast. Also, contrast material is very hard on the kidneys and can cause renal failure, especially in patients who already have kidney disease. Thus, all patients requiring IV contrast should receive lots and lots of IV fluid in advance of the study, and if a patient does have a history of kidney disease, they should also receive sodium bicarbonate and N-acetylcysteine, which have a protective effect on the kidneys. Finally, certain medications are contraindicated with IV contrast, and the one you should know for the exam is metformin. Metformin is a renally excreted drug, and if it is unable to be excreted, it can induce a life-threatening lactic acidosis. Because IV contrast presents a serious risk for kidney injury, as just discussed, metformin should be discontinued before a patient receives IV contrast to minimize the risk of lactic acidosis. Let's now move on to discuss indications for specific types of CT scans, and we'll start with the non-contrast head CT. Because no contrast is given, this is a fast and safe way to evaluate brain tissue and the surrounding structures. Any patient who experiences a traumatic head injury should be considered for a non-contrast head CT. But if your question stem describes a patient who has lost consciousness or who is altered, you must order a stat non-contrast head CT to evaluate for an intracranial lesion that could be responsible. The initial test for a patient suspected of having a stroke is also a non-contrast head CT. So if you are asked about a patient with unilateral weakness, slurred speech, or any of the other classic stroke symptoms, get a non-contrast head CT. Note that the CT will not only tell you if the patient is having a stroke, but can also distinguish between hemorrhagic and ischemic strokes. This is a vital piece of information because you must quickly treat patients with acute onset ischemic strokes with TPA, but doing so could kill a patient experiencing a hemorrhagic stroke. Finally, brain bleeds are also best evaluated with a non-contrast head CT. So if you suspect that an elderly patient who fell and hit their head has a subdural, or if you get the classic epidural story of a young person who was hit in the temple and lost consciousness, then had a lucid period before again losing consciousness, you must evaluate with a non-contrast head CT. On a normal non-contrast head CT, like the one seen here, it is important to remember that bone is bright white, but blood is also white, especially pooled blood that results after hemorrhage. This is because hemoglobin is dense and is capable of absorbing the X-rays. CSF, on the other hand, does not have hemoglobin and thus appears dark. Perhaps the most important thing to note on any brain CT scan is symmetry. Both sides of the brain should appear symmetrical, and if there is asymmetry present, it means that something is wrong. We will now review some of the classic pathologic findings seen on non-contrast head CTs that may appear on your Step 2 CK exam, starting with ischemic stroke. As we discussed, blood appears white on CT, so an ischemic area of the brain that is not receiving perfusion will appear darker than normal brain tissue. This is depicted by the arrow on the image to the right, which points to a massive area of brain ischemia. Another finding seen with ischemic strokes is blurring of the gray-white border. Note how in the left brain you can make out the difference between the outer gray matter and the inner white matter. In an ischemic stroke patient, this border becomes indistinguishable. The final finding that is common to both ischemic and hemorrhagic strokes is asymmetry of the brain tissue secondary to mass effect, which is best appreciated here by looking at the ventricles. Note how the right ventricle is being compressed compared to the left. This occurs because there is swelling of the brain tissue due to edema, and this edema is compressing the normal brain tissue. If you see an image similar to this on your exam, you should immediately be able to diagnose an ischemic stroke and must get this patient TPA if you are still within the acceptable time window. Contrast the previous image to the one seen here. This is a classic example of a hemorrhagic stroke. Blood appears white, especially pooled blood, so the area depicted by the red arrow is the location of the brain bleed. Because blood takes up space in the confined cranial space, hemorrhagic strokes also lead to mass effect, which can be appreciated here by noting the asymmetry in the anterior portion of the ventricles. Another difference between hemorrhagic and ischemic strokes on non-contrast head CT is that with hemorrhagic strokes, the gray-white border remains intact. Let's now move on to discuss two other conditions that can be easily diagnosed via non-contrast head CT, starting with the subdural hematoma. A subdural hematoma results from a traumatic head injury that leads to tearing of the veins that bridge the dura. As you'd expect with any sort of brain bleed, the lesion is bright and is found adjacent to the skull. The crescent-like shape of the intracranial blood is key to differentiating this condition from an epidural hematoma. Because the blood is accumulating inside the dural sac, it is not confined to the sutures of the skull, and thus is able to spread adjacent to the skull, forming this classic crescent shape. Subdural hematomas also cause mass effect, leading to compression, as can be seen in the left ventricle on this image. The final high-yield pathologic finding on non-contrast CT that may appear on your exam is that of an epidural hematoma. Epidurals are caused by tearing of the middle meningeal artery after trauma to the temporal region and are very frequently associated with skull fractures, which is highlighted by the skinny arrow. Blood is again located adjacent to the skull with epidurals, but in this case the shape is that of a biconvex disc as opposed to a crescent. This is because epidural hematomas cause bleeding outside of the dura and is therefore confined to the region between skull sutures. The mass effect associated with an epidural hematoma is extremely dangerous. While subdurals are the result of a venous tear, epidurals occur secondary to an arterial tear, meaning that the pressure associated with epidurals is much higher and can lead to the dreaded complication of an uncal herniation. Thus, if you see this image on your exam, you should recommend that the patient receive an immediate craniotomy to relieve the pressure that has built up on the brain. While non-contrast head CTs will definitely receive more attention on your Step 2 CK exam because they are used to diagnose commonly tested conditions like strokes and brain bleeds, you should also be familiar with the indications for contrast-enhanced head CTs. IV contrast causes vascular tissue to light up as bright white, and thus is useful for evaluating infected tissues, which receive increased blood flow in an effort to fight the infection, as well as tumors, which are often highly vascular. Every patient with suspected meningitis should have a lumbar puncture performed, although caution should be used in patients with evidence of raised intracranial pressure, thrombocytopenia, bleeding diathesis, or spinal epidural abscess. A screening CT scan is not necessary in the majority of patients, but one can be performed prior to LP in order to exclude a mass lesion or raised intracranial pressure, which can lead to cerebral herniation during LP. Also, if a patient presents with focal neurological deficits that is concerning for an intracranial mass lesion in the brain, the best test for these patients is a head CT with contrast, which can identify the presence of an abscess, a primary cancer, or metastatic disease. The image to the right is a normal appearing head CT with contrast. Note that the blood vessels appear bright white. The image to the right displays the classic appearance of a primary brain tumor, which in this patient is located in the posterior fossa of the skull. Primary tumors are single lesions, so if you see multiple lesions on contrast head CT, you should assume that you are dealing with metastatic disease. Because brain tumors require significant blood flow to help them grow, they are highly vascular and will appear brighter than the surrounding tissue, as is depicted by the arrow to the right. Like bleeds and edema, tumors also take up volume in the intracranial cavity, and thus mass effect is also present with tumors, which again will cause asymmetry. It should be noted that on the contrast CT, a brain tumor is indistinguishable from an abscess, and thus you must use the clinical data provided in the question stem to help differentiate these two conditions. So if they mention a fever in the presence of focal neurologic deficits, lean towards an abscess. Distinguishing between metastases and primary tumors is often as easy as counting the number of lesions. More often than not, if there is more than one tumor, the cause is metastatic disease, as seen in the image to the right. Again, these tumors are vascular and therefore appear bright white, and while it cannot be appreciated in this image, the metastases are almost always located at the gray-white border of the brain. This is because tumor metastases to the brain are carried through the bloodstream, and at the gray-white border, the vessels quickly branch into capillaries, which provides the perfect location for tumor cells to drop roots and begin growing. As expected, mass effect is seen with metastatic tumors as well. Let's now move on to a second region of the body where CT scans are commonly utilized, the abdomen. When evaluating organs in the abdomen, you really should only consider two imaging modalities, CT scan and ultrasound. We will talk about ultrasound at length in the next lecture, but it is generally poor at looking through bony structures due to the shadows that bone casts, and is also poor at looking through air-filled structures like the bowel, because air refracts the sound waves. Thus, its use in the abdomen is somewhat limited to evaluating the gallbladder, liver, kidneys, and female reproductive organs. CT scans are the test of choice for looking at certain retroperitoneal structures, so if a patient presents with mid-epigastric pain that radiates to the back, consistent with pancreatitis, a CT scan is the diagnostic test of choice. Furthermore, CT can be useful in detecting adrenal tumors, although with a pheochromocytoma, your first diagnostic step should be a urine screen for VMA and metanephrine. CT is also the best test to evaluate for intraperitoneal inflammation, so if a patient presents with right lower quadrant pain or left lower quadrant pain, consistent with appendicitis or diverticulitis respectively, the workup should include a CT scan. And while kidney stones can sometimes be diagnosed via ultrasound, or even on plain films, the test of choice on your Step 2 CK exam for nephrolithiasis is a CT as well, and is indicated in any patient presenting with colicky flank pain. Unidentified masses in the non-gynecologic abdominal organs should also be worked up with a CT scan, even liver tumors. While a good ultrasonographer may be able to visualize a liver tumor, CT remains the test of choice for this indication. And finally, splenic lacerations are often very small, but since CT is a great test to evaluate for pooled blood, it is the test of choice to rule in or rule out a splenic laceration. So on your exam, if you come across a patient who has experienced trauma and is now complaining of pain in the left upper quadrant and left shoulder pain, order a stat CT to make sure the patient doesn't have a significant splenic bleed. Before we discuss the appearance of a normal CT scan and then look at some of the classic pathologic findings on abdominal CT, let me mention that with the routine abdominal CT exams, the patients are not only given IV contrast, but oral contrast as well. This allows for better differentiation of the blood vessels as well as the bowel wall. This is an example of a normal contrast-enhanced abdominal CT scan taken at the level of the kidneys. Note that the border of each abdominal organ is relatively crisp or distinct. When these borders become wavy or irregular, it is evidence of a local inflammatory process. Also note that air appears black on CT. While it is normal for air to be present within the lumen of the bowel, as it is on this image, if you ever see air outside of the bowel, it is pathologic and a sign that the bowel has perforated. Having seen what a normal abdominal CT looks like, let's go over some of the common abnormal findings that come up over and over again on the Step 2 CK exam, starting with pancreatitis. Pancreatitis is inflammation of the pancreatic tissue, and as with all inflammatory processes, this will cause blurring of the visceral borders, as can be seen in the area highlighted by the red oval. The pancreas will also appear larger than normal because edema occurs as part of the disease process and causes tissue expansion. This edema will also be grossly apparent as fluid in the retroperitoneal space. A very common condition, especially in younger adults, appendicitis is associated with the classic physical exam findings of right lower quadrant pain, located at McBurney's point, and rebound tenderness. But there are also specific abdominal CT findings associated with this condition. First, as occurred in the pancreas with pancreatitis, the appendix will appear enlarged, and on the offhand chance they give you a specific measurement, anything bigger than 6 millimeters is abnormal. The appendix wall will also become very thick, as you should be able to appreciate from the borders of the appendix seen in the image below. Another finding you may be able to appreciate is so-called fat stranding near the organ, leading to a wavy appearance surrounding the inflamed appendix. And finally, appendicitis most commonly occurs because a fecalith impacts into the lumen of the appendix, leading to obstruction. Thus, when oral contrast is given to these patients, it lines the entire gut with the exception of the appendix because the fecalith blocks the dye from entering. Thus, a large appendix that doesn't fill with contrast is pathognomonic for appendicitis, and if you see an example of such a CT on your exam, you should pick the answer choice that includes a laparoscopic appendectomy. Continuing with the theme of intraperitoneal inflammation, diverticulitis occurs due to inflammation of the outpouchings of the bowel wall, most commonly in the sigmoid colon. Like appendicitis, a classic finding on abdominal CT with diverticulitis is thickening of the bowel wall in the inflamed areas, as well as localized fat stranding, which is depicted by the arrow. Another finding that makes it easy to diagnose diverticulitis is the presence of the diverticula themselves, which appear as small, air-filled sacs in the bowel wall. A few examples can be seen in this image and are depicted by the left arrow. While acute diverticulitis seen on the exam should be associated with an image very similar to this one, it is also possible for the diagnosis to be missed for a period of time. And if the diverticulitis has advanced, there may be an abscess visible on the CT scan as well. The final condition you should be comfortable identifying in an abdominal CT image on your Step 2 CK exam is nephrolithiasis or kidney stones. While some stones are radio-opaque and can be seen on a KUB or upright abdominal film, CT scans are much more sensitive for kidney stones, which can be visualized as a small calcification either within the ureter or in the kidney itself, as depicted here by the red arrow. Along with the actual presence of a stone, CTs can also reveal the presence of hydronephrosis, indicating that the stone is obstructing the urinary tract, leading to a pressure buildup within the kidney. And, if the patient's symptoms aren't actually caused by a stone, then a CT scan may provide information about the true cause of the pain, something that X-ray and ultrasound cannot offer. For all of these reasons, if you suspect a kidney stone on your exam, you should order an abdominal CT to confirm. There is one caveat, however. Unlike all other abdominal CT scans, in which contrast is desirable, you do not want to give patients suspected of having a kidney stone contrast, neither oral nor IV. The reason for this is simple. You are trying to identify a calcified stone, which will appear white on the image, so you want everything else to be as dark as possible. The final high-yield indications for CT on your exam are in the thoracic cavity, as chest CT is a fantastic way to evaluate pathology in the lung tissue, as well as in the vessels of the heart and lung. While chest X-ray is the first-line test if a patient presents with cough or hemoptysis, anytime a possible mass lesion in the lung is seen on X-ray, it must further be evaluated with CT, which can provide more detail about the size and structure of the lesion. Furthermore, the 4 T's of mediastinal masses, thymoma, teratoma, thyroid tumors, and terrible lymphoma, should also be imaged with CT before they are biopsied. Diseases of the lung tissue itself should always be evaluated with CT. So if you have a patient with a dry cough for whom you suspect interstitial lung disease or sarcoidosis, or if a chest X-ray reveals hilar lymph node enlargement, which is often seen in sarcoid, a chest CT should be ordered. Bronchiectasis has the classic CT finding of dilated, inflamed bronchi. So if a patient is coughing up large amounts of green or yellow sputum, the classic symptom of bronchiectasis, they should receive a chest CT as well. Cavitary lung lesions seen on X-ray can represent a variety of conditions, including tuberculosis, cancer, Wegener's granulomatosis, as well as cysts or abscesses, and thus a CT is necessary to help differentiate between these conditions. Finally, chest CT has 2 other key indications. The first is that a special type of CT, known as a CT pulmonary angiogram, is the test of choice to diagnose pulmonary embolism. So if you have a high suspicion for PE in a patient with acute onset shortness of breath after a period of prolonged immobility, you should get a stat CT pulmonary angiogram to confirm the diagnosis. This is a very high yield topic and one that we will discuss further shortly. The image on this slide is a normal chest CT with contrast enhancement. Note how the great vessels and lung vasculature appear bright white. As with a normal abdominal CT, the borders of all of the structures are very distinct, and it is when this crisp appearance disappears that you must start to worry about inflammation. Alright guys, that's it for this lecture about computed tomography. In the third and final radiology session, we will discuss other advanced imaging techniques, including MRI, ultrasound, and a few of the common nuclear medicine studies that appear on the exam. Keep up the strong work, everyone.